So without any further ado, let's start with something I think that's very important here today. The first session, so you could take a look at the program. We have about, 7 sessions today, or 8 sessions. And, by topic, which I think would be important for you no matter what you're doing. And the first one may touch not only your patients and your loved ones, but yourself, is what's risk? Cardiovascular risk, coronary disease. And how can we reduce it? And let me tell you, among the best speakers I know in this medical center is Dr. Peter Jones. He's a friend over the years. We've trained together, and he's an amazing authority on lipids, cholesterol, risk. And we gave him 2 tasks this morning. Am I at risk for a heart attack? And statins and beyond. Is it for everyone? Peter, Associate Professor of Medicine at Baylor College of Medicine, and a wonderful colleague over the years. Peter, it's great to have you here.
All right, so he's given me the task to try to get things going and tell you how to prevent everything else you're going to hear the rest of the day. Prevent cardiovascular disease. My whole career has been in prevention. I'm a lipid expert, but I also work at Houston Methodist in the weight management program as well, because it's a critical part of what I do in lipid disorders. So the obvious question is, am I at risk for a heart attack? The answer is yes, everybody is. We'll talk a little bit more about that, but if you live long enough, yeah, chances are cardiovascular disease could be in your life. Let me just start with things you probably already know, but I just want to put it in perspective. This is the Inner Heart study. This was a huge population evaluation, 52 countries, so it's multi-ethnic, cultural, looking at 15,000 cases as well as controls. And they looked at risk factors for cardiovascular disease and what they call population attributable risk, PAR. And they found that 9 risk factors are responsible for 90 to 95% of cardiovascular disease in the world. And here they are. The positive associations are smoking, lipid abnormalities, ApoB are the bad lipoproteins, ApoB containing lipoproteins, ApoA1 is the HDL, so this ratio would be more bad ApoB particles than good. History of hypertension, diabetes, obesity, specifically abdominal obesity, and psychosocial factors. In other words, lower socioeconomic and educational levels tend to be strong predictors of heart disease. So if you look at the population attributable risk, the 3 worst ones are smoking, lipid abnormalities, and psychosocial factors. Next would be hypertension and abdominal obesity. Now, the other 3 have an inverse relationship. In other words, they tend to be protective. So if you tend to have the highest intake of fruits and vegetables, a lower risk of heart disease. Regular alcohol consumption doesn't mean a lot. It just means that you do it once a day. Yeah, just got to be very, very careful with that one. And then regular physical activity. There's some population attributable risk there, but those have inverse relationships. So if you know those 9 factors, depending on age and gender, you can predict up to 95% of your risk of cardiovascular disease with those. So we all know that, right? We ask those questions of patients. What I want is to hope that this thing will move to the next slide. There it goes. It's just to look at it from the fact of what can you as a practitioner do and what can you not do? Well, some of the factors we can't change, right? Age, if you get older, you're going to have a higher risk of heart disease. Can't change that. Your family history is genetics. We cannot change that. And males tend to have earlier heart disease than women, and you can change this, but it's really mostly not modifiable for most of us. The ones we do focus on in our practice tend to be whether they smoke, their lipid problems, hypertension, obesity, whether they're physically inactive, and the presence of insulin resistance, which, as I'm going to show you a little bit later, is the metabolic syndrome, and how lifestyle can probably influence, even if you have a genetic tendency there, your risk of diabetes. I'm trying to figure out how easy this is to get it to change to the next factor. In 2013, the AHA-ACC came out with blood cholesterol guidelines, and part of that was a risk calculator for primary prevention. And they used some of the factors I just told you about to come up with this risk calculation. So if you look at it, it's gender, it's age, it's race, it's lipids, which in this case, it's total cholesterol and HDL. If you look at that, I'm going to talk about this a little bit later, if you know the total cholesterol, you know the HDL, what you're actually figuring out for the patient is non-HDL cholesterol, which is all the bad lipoproteins, the ApoB containing lipoproteins. So total cholesterol minus HDL is the non-HDL cholesterol. You know the blood pressure, whether they're being treated whether they have diabetes or smoking. So you can put those into this pooled cohort equation, and it gives you a 10-year risk of heart disease, and it will also give you a lifetime risk if you tend to be younger. So if you're under age 50, it'll give you a lifetime risk because people who are younger tend to have low risk anyway because younger age primarily drives the risk. You know, and we say, oh, if your 10-year risk is more than 10% or 15%, you tend to be sort of a higher risk for heart disease, and you should be doing something to reduce that risk. It's hard to talk to patients in those kind of percentages because, you know, I had a patient from Louisiana who sort of likes to go to casinos, and you tell him, you know, he's got a 15% risk of heart disease in the next 10 years. He sits there and goes, oh, okay, so that means a 6 out of 7 chance I'll be okay. And he says, those are good odds to me. And you're trying to get him to focus on the 1 out of 6, 1 out of 7 that's the problem for him. But it is the higher the 10-year risk, the more the cost effectiveness and the importance is of treatment. So lifetime risk does come important for talking about older, younger people. And again, I seem to have, there we go. What I want to do is spend a little bit of time on the lipid side because that's what I do best and something that you can really impact in your patients. Not surprisingly, LDL cholesterol predicts cardiovascular disease. Bad cholesterol is bad for you. So observationally, LDL cholesterol is bad for you, and observationally, it looked like HDL cholesterol was protective. We thought HDL was the good cholesterol. Well, more recently, we've got now genetics, and with genetics in huge populations, we can come up with Mendelian randomization kind of look at lifetime risk related to what you inherit. And when you look at the genes that cause increases in LDL, yeah, guess what? It is causative. You inherit high LDL, it is going to cause premature heart disease. But you know what? What they found is that the genes that cause high HDL aren't as protective as we thought. So this question of why does HDL seem to be inversely associated with heart disease observationally, but if you inherit a high HDL, it's not as protective as we thought, tends to be related to confounding. And most of the patients who tend to have low HDL also tend to have insulin resistance. They have high triglycerides, central adiposity. And what happens is that HDL is probably a marker of those things which are more likely to be related to cardiovascular disease. And as you'll see in the next slide, if I can get it to go, it looks like you're going to have to change them from the back, is that triglycerides are now causative of atherosclerosis. This has come out within the last 5 years, again, using genetics and the Copenhagen, and they tend to have all their populations are required to sort of get lab done and commit to a gene trial. So the Copenhagen City Heart Study, the general population, the ischemic heart disease populations, looked at genes that are related to higher or lower triglycerides. And in the first one, higher triglycerides, non-fasting and remnant cholesterol, which is non-HDL cholesterol, is significantly associated with cardiovascular disease, and genetic variants that cause lower triglycerides, increase in lipoprotein lipase activity, are associated not only with lower cardiovascular disease, but lower mortality. So these people inherit tendencies for either high triglycerides all their life or lower triglycerides all their life, and they tend to have opposite effects on cardiovascular disease. And again, this was published in the European Heart Journal, 17 studies looking at genetic scores for LDL, triglycerides, and HDL, and again confirms that LDL scores, higher LDLs are strongly associated with heart disease. Triglyceride scores, higher triglycerides are strongly associated with heart disease, but the HDL score is not associated with protection against cardiovascular disease. So the ApoB containing lipoproteins are the most important part, and I just want to make sure you understand that. In the next slide, if you can move them for me because it tend to be working too well here. Just another one that just came out about ApoC3. I don't want to get too granular about this, but if you have a loss of function, and they looked at these that cause lower triglycerides, so triglyceride levels all their life are at least 40% lower than compared populations, there's again a 40% lower risk of cardiovascular disease over time in these populations, almost 111,000 participants in this. Now we'll take a look at some of the other risk factors for cardiovascular disease. Metabolic syndrome, I hope you know what that is. I'll talk about it a little bit. Poor cardiorespiratory fitness, a lack of physical activity is a strong predictor of cardiovascular disease. Chronic inflammatory diseases are now being understood to increase your risk of vulnerable plaques and premature coronary disease, rheumatoid arthritis, psoriatic arthritis, and lupus. Another chronic inflammatory disease, HIV. CKD, stage 3B to 5, has a higher risk of overall cardiovascular disease. Obstructive sleep apnea, how many times we talk to patients about that? But treating it is critically important. They have an increased risk of resistant hypertension, which is hard to manage, the increased risk of atrial fibrillation, and sudden death. And so it needs to be a great article in the Journal of the American College of Cardiology just earlier this year, reviewing sleep apnea for the cardiologist. And then last but not least is dietary pattern. And I want to make a point about this. It's not about individual components of your diet that's important for health. It's a pattern of eating. And sometimes it's referred to as the Mediterranean diet, and I'll talk about that a little bit later. So let's go into some of these risk factors, if you can help me with the next slide. Is the metabolic syndrome. I think you understand this. This is a collection of clinical things you can measure that increases the risk for diabetes. It's a measure of insulin resistance, and it's central adiposity, which you use waist circumference. I'll show you how to measure that. It's dyslipidemia, which is high triglycerides, low HDL, elevated blood pressure, prediabetes, which is impaired fasting glucose. And all of this tends to increase your risk of inflammation as well as procoagulant. Now, metabolic syndrome is easy for you to identify. It's also easy to treat because it is amenable to lifestyle changes. Weight loss and physical activity are the best ways to improve insulin sensitivity. So waist circumference is measured at the iliac crests at the level of the umbilicus. Iliac crests at the level of the umbilicus. Never ask a man what his waist circumference is, because they give you his belt size, which is way underneath the, most men, their belt buckle is facing the ground. So, measure it properly and you'll get the real. All right, so the next slide, if you can move it forward for me. Whoops, now it gets to go. These are the measurements. So it's waist circumference, different for men and women, triglycerides, HDL levels, blood pressure, and fasting glucose. Those are the 5 measurements that you should be able to identify. This will be in your handouts when you look at them. Additional risk factors, I just want to make sure you know about the non-HDL cholesterol. When you get the fasting lipid profile, yeah, it is about the LDL, it is about the triglycerides, but if you subtract HDL from total cholesterol, you'll get this total component, triglycerides and LDL, as the risk of atherogenesis. If you want to look at A1C, look at prediabetes or undiagnosed diabetes, easily can do that. There's specialized lipid tests. Lp(a) is a genetic risk for cardiovascular disease. I just want to make sure that in some patients with very premature heart disease, that is one specialized lipid test you should probably get. Next slide. Hope the next speakers don't have as much difficulty as me. Oh, there we go. Lifestyle, what should you do? Lose weight, measure waist circumference, and use BMIs or whatever it is to tell the patients to lose weight. Exercise at least 150 minutes a week, moderate intensity. And I use FIT to talk to the patients. FIT, frequency, intensity, and time. 3 times a week, moderate intensity, 30 minutes. Okay, that's 90 minutes. Whoops, we got to get up to 5 times a week, moderate intensity for 30 minutes. Okay, now I've got 150 minutes a week, so get fit. Don't smoke, and do a pattern of eating that focuses on fat is okay if it's the right kind of fat. Nuts and olive oil are monosaturated fats and omega-6s. Those are all good. Eat non-red meat, fish and poultry. Fabulous fish gives you omega-3s. And focus on fruits and vegetables, which are not high in glycemic index. And the next slide. I just want to show you an example. I sometimes use this on patients if you can help me. This is a ruptured plaque, bad. You're going to hear more about how to deal with this. Here's the plaque, lipid-rich, ruptures at the side, intraluminal thrombosis, intraluminal thrombosis and intraplaque hemorrhage. Next slide. This is not what you're supposed to eat. So this slide should look very similar to the next slide. All right? There's your lipid-rich plaque. There's your intraluminal hemorrhage. And so next time when you look at one of these taquitos, it should remind you what you're doing to yourself, okay? So don't do it. All right? Next slide. And lifestyle does work. Health professional follow-up study. If you do 5 lifestyle changes, you can reduce your risk of cardiovascular disease, even if you have dyslipidemia, hypertension, taking medicines. If you follow most of these lifestyle changes, you can reduce your risk of cardiovascular disease. Even if you just adopt 2 of them, you can lower your risk of heart disease compared to those who don't. These are healthcare professionals. And if you do all 5, then you can push the next button. It should show up in the bottom. You'll get over a 60%, almost a 60% lowering in cardiovascular risk. Okay? So it does work. So tell your patients that lifestyle is really important. Last thing I want to tell you about genes. Some people say, well, it's in my genes. I can't help myself. It's terrible. Well, this is a genetic score, and 3 different populations over 10 years looking at genetic risks, low, moderate, or high. And you can tell that if you have favorable lifestyle changes, even in the high genetic risk scores, you can significantly lower your future risk of coronary heart disease with lifestyle. And lastly, coronary calcium, which you'll hear about a little bit later. Same thing is true even with your genetic risk. That's your risk of coronary calcium scores, low, moderate, or high. If you have a favorable lifestyle, you can significantly reduce your future risk of heart disease, even if you have a high calcium score. So, are there other objective tests? You're going to hear about these later, stress testing, coronary calcium score, carotid IMT. What else can you use to determine risk? I'm just going to say I think coronary calcium score is the best. You'll have a list of pros about exercise stress testing and all. But I think that coronary calcium score, if you have a 0, you are in excellent outcome. So getting a score, if you're 0, you're in a good place. If your calcium score is high, you end up needing to be on preventative treatments. And at least the Society of Cardiovascular CT experts put out a consensus just recently saying that if you are primary prevention and your 10-year risk is anywhere 10 or 15%, get a coronary calcium score. And the higher your score, they recommend not just lifestyle, but possibly moderate to high intensity statins. Summary. Of the major risk factors, age, hypertension, dyslipidemia, insulin resistance, smoking, poor cardiorespiratory fitness, and family history. They're all there. Major cardiovascular disease events does relate to these. That's the inner heart. Modifying them with therapeutic lifestyle change and medical therapy is crucial in secondary prevention, but very important in primary prevention. Spend time talking to high-risk patients about primary prevention strategies. And if you want to do additional tools to use to decide on primary prevention, I would recommend coronary calcium scoring.